Hello, my name is Todd Rice, and I'm the Director of the Medical Intensive Care Unit and an Associate Professor of Medicine at Vanderbilt University Medical Center in Nashville, Tennessee. Today's course is just one in a series of subjects brought to you by Channel 1, On-Demand Nutrition Education. Today, we are looking at the second part of the 2021 ASPEN Guidelines update for the critically ill adult patient. What did we do in these guidelines? So first, what we did was we put together a multidisciplinary team. This is very important for ASPEN that it be multidisciplinary. And you can see from the author list that I'll show you on the next slide, it contains dietitians, physicians, epidemiologists, pharmacists that are all involved in nutritional care, all as part of a team to update these guidelines. And our purpose was to critically evaluate any new data for up to 9 questions and provide updated recommendations for these questions from the 2016 guidelines, specifically questions where there were new randomized controlled trial data. And the goal here was not to update all of the guidelines. A lot of the guidelines are expert opinion that don't have data or randomized controlled data to support them. The goal was to take new randomized controlled data, put them in the right question and use them to answer that question and update the answer to that question. And hopefully you'll see that as we walk along. Here's the title and the byline of the manuscript, and you can see there are dietitians, there are physicians, a nutrition epidemiologist or two, a pharmacist, and a nurse representative in this team for the authorship. In the beginning, we had 8 PICO questions to which we wanted to examine and try and update the answers to based off of new randomized controlled trial. You can see the 8 listed here. The first 5 are in black, and those are the ones that we actually found new data and updated the recommendation for. The last 3 we won't talk more about. Just to tell you, we did do a search, a literature search for these. Didn't find any new randomized data or any new data on a couple of them at all. And so we didn't actually move forward in updating the literature on this. The immunoenhancing question, there actually are some new data, but it was so heterogeneous with the different molecules and the different nutrients that we decided that this needed to be its own update and stand alone on its own. So it's not included in this one. And that's why it's in red here. We had a couple kind of rules, so inclusion criteria. The goal was to try and update these data for critically ill adult patients that are being cared for in surgical, medical, or mixed ICUs that can't provide their own volitional oral intake and therefore are prescribed either parenteral or enteral nutrition, or in some cases both, but nutritional support, artificial nutritional support that they're not necessarily taking on their own. The inclusion criteria were that you had to have a randomized controlled trial. It had to be in adults, which technically we included a couple of the later teenagers, 16 and 17-year-olds, but that's in the inclusion of adults. Again, an intervention that included EN or PN. You had to report clinically important outcomes, and the ones that we specifically were looking for were new infections, the time that you spent on mechanical ventilation, mortality. You'll see there's some 28-day mortality, there's some hospital mortality, there's some 90-day mortality, but you had to have a mortality outcome at some point, or length of stay, ICU or hospital length of stay. And then we limited the search to manuscripts that were published or at least available in the English language. There are some differences between this and the 2016 guidelines. We talked about a little bit about the fact that it's randomized controlled data only, no observational studies or meta-analysis from others, no quasi-randomized trials. But in addition, we limited the publication time period from January 1st of 2001 through July 15th of 2020. And we specifically were looking at adult critically ill patients, not separate recommendations according to diagnosis. So you'll notice there's not a pancreatitis or a liver failure subgroup or recommendation for those specific populations, because we were looking at adult critically ill patients in general. We paid careful attention to the actual delivery of the amount of energy and protein that was prescribed and delivered. And then most of the trials that we found have overweight to obese patients based off of their mean BMI. We looked at citations after we did a search in duplicate. So 2 of the authors would look at a citation and say whether or not they thought that citation might be appropriate. Then we went and pulled the articles that we thought might have any pertinence at all, screened the articles again in duplicate, and if they were meeting our criteria and providing new information, we did data abstraction also in duplicate. So all of the kind of deciding which articles were appropriate and in the new updates were done in duplicate. And then there was a bias assessment for each outcome of each study using a standardized Cochrane risk of bias 2 form. Statistical analysis, I'm not going to get into a ton of details here. There's just some important highlights. One is that you'll only see forest plots if there were equal to or more than 3 studies for a given outcome. So if there were only 2 studies that reported new infections, you won't see a forest plot because there were only 2 studies. But if there are 3 or more, then there's a forest plot figure that I will show you. The model was a random effects model with a significance threshold of 0.05 for significance. And I will report the results either in a difference, which is a difference in percentages, or a mean weighted difference, which is a continuous outcome and is a difference usually in length of stay in days. So I'll go through that again when I show you some specific results. The other thing to note is that we were asked by reviewers when we submitted the recommendation, the updates, to look at both protein and calories and try and facilitate recommendations for specific cut points based off of the data. So this was done in a post hoc safety analysis, and I'll show you kind of these results also. But I think it's important for you to know that this was not our plan going in. This was done in response to reviewers in a post hoc way. What we did here was we assessed hospital mortality across an available range of energy delivered in kilocalories per kilogram per day. And I'll show you those plots as we get to them in a few slides. In order to make sure that we kind of had balanced out as much as we could, we stratified this analysis by Apache 2 score, by country, by medical system, and by BMI. You will see 2 parts to each recommendation. The first is a grade approach where there is a quality of evidence. It tells you how good the evidence is. It's based off of an objective analysis of what is the risk of bias of the studies, what is the consistency or inconsistency of the studies, what's the precision of the results, and then is there a potential publication bias with what publications are out there. There's also a strength of the recommendation, how weak or strong that strength is. That's based off of both potential benefits and harms and an analysis of those regarding the recommendation. There are 2 that you will see. One is suggest. That means it's a weak recommendation. The other is the word recommend, and that is a stronger recommendation. So the second part of this is the other 2 learning questions, learning objectives for the other 2 questions, 4 and 5. And specifically here, we're going to talk about the data driving a new supplemental parenteral nutrition recommendation and the data on different intralipid emulsion compositions and what we can say about those, understanding the nuances of implementing these new guidelines in clinical practice. We've already talked about this multidisciplinary author team, but the one thing I want to point out is that remember, guidelines are intended for use by clinicians, but they're not absolutes. And you should use clinical judgment in the care of your patients and not just blindly replace all of your clinical judgment with anything that's written in the guidelines. All right, here's your case. 48-year-old male, septic shock ARDS, day 3 of mechanical ventilation, off pressors. Enteral feedings were started, good, but patients only getting about 40% of their energy targets by enteral nutrition because they're having stoppages in this stage of their critical illness and they're having some GI intolerances. And the question is, what would you do? And your options really are kind of keep on keeping on. I'm going to keep pushing enteral nutrition and do the best that I can. You may want to start prokinetics or put a feeding tube post-caloric in these patients. Second option would be say, okay, they're getting about 40%. I'm going to supplement them with parenteral nutrition to get them to a number 80%, maybe 100% of their goal to provide full enteral energy target or full energy targets from a nutrition standpoint. So that leads to the question. The question in the guidelines to answer this is, in adult critically ill patients that are already getting early enteral nutrition, but not necessarily meeting their goals, does provision of supplemental parenteral nutrition to help them meet their energy targets versus not giving them supplemental parenteral nutrition and just letting them getting the amount of energy delivered that's below their target during the first week of critical illness impact clinical outcomes? To be included, you had to have trials that reported differences in outcomes in response to supplemental parenteral nutrition, SPN, versus not, or just standard of care as one of the arms. In critically ill adult patients, there's 6 RCTs, again, almost 6,000 critically ill patients that met the inclusion criteria for this question. You guys know this, supplementing enteral nutrition with parenteral is using parenteral to increase caloric delivery. You usually taper off the parenteral as they're able to tolerate, the patient's able to tolerate more enteral. And the 2016 ASPEN guideline recommended that patients at either low or high nutrition risk, use of supplemental PN be considered after 7 to 10 days if you're not able to meet greater than 60% of your energy and protein requirements. Initiating it within that first 7 to 10 day period on patients who are already on EN doesn't seem to improve outcomes and may actually be detrimental to the patient with a moderate quality of evidence. So here are the updated data for supplemental versus no supplemental for what I'll show you is ICU first, then hospital, then 90-day mortality. Here, no difference in ICU mortality, a point estimate of -1% difference, which would technically favor the supplemental parenteral nutrition, but is nowhere close to statistically significant. If you look at hospital mortality, you see almost the exact same thing. The point estimate here is actually 0% difference between the groups, with, again, confidence intervals that cross the null. And for 90-day, again, 0% differences in mortality, confidence intervals that cross the null, nowhere close to significance. So really no difference in mortality between supplemental and no supplemental parenteral nutrition. What about with bacteremia? Bacteremia slightly favors the enteral nutrition without supplemental parenteral nutrition with a p-value of 0.18. It does not reach statistical significance. If you look at pneumonia, again, slightly favors the no supplemental parenteral nutrition, but crosses the null hypothesis and is not statistically significant. And if you look at any infection, whether it be bacteremia, pneumonia, urinary tract infection, et cetera, pretty much the same outcome, no difference in any infection between the two. Given that, the recommendation is since there's not a significant difference in clinical outcomes, based on the fact that there's not an important clinical benefit in providing supplemental parenteral nutrition, we suggest not initiating supplemental parenteral nutrition prior to day 7 of ICU admission. And the reason it's that specific is that's what was tested in these trials, was during the first week of ICU admission. And the data for supplemental parenteral nutrition after day 7 is much less robust and is not really definitive in telling us what we should do. There are some data that suggest that maybe increasing feeds with supplemental parenteral nutrition after that first week may be beneficial, but we need better trials and data to demonstrate that that's truly true. The quality of evidence for this recommendation to not initiate supplemental PN prior to day 7 is high with a strong strength of recommendation. We've already talked about these. The nuances here are that the trials only evaluate supplemental parenteral nutrition early in the ICU course, i.e. the first week, and that the data for what it does, what the effects are of supplemental parenteral nutrition after that first week are much more limited. This doesn't necessarily mean that this translates to other populations. So if you have somebody who has GI issues but is not critically ill, these data may not translate to that population. It certainly doesn't translate to patients who are already malnourished. Those patients were excluded from the trials, and we need data on those patients to better understand what we should do. Here's the second question. A 60-year-old female with pancreatitis and ARDS, day 2 of mechanical ventilation, patient remains on pressors. Due to pancreatitis and pressors, the team decides that they're going to initiate parenteral nutrition. What intralipid emulsion would you use in your parenteral nutrition? A mixed oil intralipid emulsion, 100% soybean oil intralipid emulsion, 80% olive oil, 20% soybean oil, or any intralipid emulsion that contains fish oil. I don't care necessarily what its composition is. I just want it to have fish oil in it. So for those that like pictures, here's kind of the picture. And the question is, this is your parenteral nutrition. We're putting all these things in it. What should the composition of this fat bottle be? Should it be soybean oil? Should it be mixed oils? Should it be any of those might be okay, but it needs to include fatty fish oils, fatty acids as part of the parenteral nutrition. So we broke this into 2 questions. Question 5A actually asks, should we compare any mixture with just purely 100% soybean oil, and how does that impact clinical outcomes? To be included, again, you had to be critically ill. We had to compare a parenteral nutrition composition that had a mixed oil intralipid emulsion with one that was 100% pure soybean oil. And you had to report relevant clinical outcomes. We've talked about this: infections, mortality, length of stay. We found 7 randomized trials that met these criteria, totaling 624 patients. All of them had as their comparator 100% soybean oil. That was required, but they had varying formulations in their mixed emulsion arms of these trials. And because of that, this precludes comparison of effect sizes in forest plots. So it's just hard to put these into forest plots when the composition of the comparator is widely variable, as it was in this situation. Usually these are used for a relatively short period of time, 12 hours to less than a month. No trial had a clinical outcome as the primary outcome, and none were powered for mortality outcomes. So we're going to be underpowered for these outcomes. And specifically here, you can see the event rates are really low. There were only 22 pneumonias, 31 bacteremias, 18 ICU deaths, 21 hospital deaths in all of the 624 patients that are in these trials. So really underpowered. Again, because we had this variability in the composition of the mixed oils, mixed intralipid emulsions oils, we don't have a forest plot. But the recommendation is that due to limited statistical and clinically significant differences, we think either mixed oil ILE or 100% soybean oil ILE can be provided at this time in patients who are appropriate candidates for initiation of parenteral nutrition early in the ICU stay, specifically within the first week of their ICU admission. The evidence here, though, is low, and this is a weak recommendation because of the low level of evidence. We need more data in this realm. The second question we ask here is about fish oil containing intralipid emulsion. And specifically, does an intralipid emulsion that contains some fish oil, at least some fish oil, how does that compare with any formulation that doesn't have any fish oil at all? And what is the impact on clinical outcomes? So most of you on this call know this. Fish oil is omega-3s. That's the right-hand side of this diagram. And when you provide omega-3 fatty acids, you end up with these 5-series leukotrienes and trianoic prostaglandins, which are at least less inflammatory than their counterparts from the omega-6, which are 4-series leukotrienes and dianoic prostaglandins. And many would argue these may be actually anti-inflammatory and not just not as inflammatory. They may actually be anti-inflammatory leukotrienes and prostaglandins. So the hope is that omega-3 fatty acids decrease inflammation and may actually fight inflammation also. To be concluded here, same thing. You had to compare fish oils containing intralipid emulsion. Sorry, you had to compare an intralipid emulsion that contained fish oils to intralipid emulsions that did not have any fish oils whatsoever as part of the PN. And it had to report relevant outcomes: infections, mortality, and length of stay. There were 10 randomized trials with a little over 900 critically ill patients for this analysis. The other thing to note is that the intralipid emulsion that was included as part of the PN regimen was done so at the time of initiating parenteral nutrition. So we aren't looking at studies where initially they provided a non-fish oil containing intralipid emulsion, and then for whatever reason, they shifted to a fish oil containing intralipid emulsion. Those aren't the trials that we included. They had to start with the fish oil containing ILE at the time of initiation of the parenteral nutrition. Again, the formulations for the non-fish oil containing intralipid emulsions varied here, but there's enough of these that I'll show you enough of these trials that I'll show you some actual figures, some actual funnel plots. The length of the intervention, the length of the parenteral nutrition was usually short, on the order of days. And again, no trial had guideline clinical outcomes as the primary outcome, and none were powered adequately for mortality outcomes. And low event rates, again, complicate the interpretation of the findings here. So here is a funnel plot for pneumonia. You can see that this actually favors the non-fish oil containing the fish oil containing intralipid emulsion. Pneumonia, the intervention here is fish oil containing intralipid emulsion. And the fish oil emulsion appeared to have fewer episodes of pneumonia developing compared to the non-fish oil containing intralipid emulsion. That is statistically significant with a p-value of 0.03. Overall absolute, about a 3% difference. But when you look at how that relates to other clinical outcomes, such as mechanical ventilation, we don't see any difference in duration of mechanical ventilation here. We don't see any difference in ICU length of stay, any statistically significant difference in ICU length of stay. We also don't see any difference in mortality, hospital mortality defined as shown here, no difference between the two, and 30-day mortality, again, no statistically significant difference between the two. You look here, and this is an 8% difference that actually favors the fish oil containing intralipid emulsion, but because there are relatively few events, as we talked about earlier, it has wide confidence intervals that cross the null hypothesis and does not reach statistical significance. All right, so that leads to a recommendation that says, due to finding only one outcome with significant difference, which was pneumonia, and that outcome is not supported by data covering the other key downstream outcomes. If you really have a difference in pneumonia, you should have a difference in mechanical ventilation duration, or ICU hospital length, or ICU length of stay duration, or ICU or hospital mortality. And we didn't see those. So having not seen that kind of confirmatory result, we suggest that either fish oil or non-fish oil containing intralipid emulsion is okay to be provided to critically ill patients within the first week of ICU admission. The quality of evidence here is low and the strength of recommendation is weak. Again, we need more data in this realm to truly understand what the effects of fish oil containing intralipid emulsion is compared to non-fish oil containing ILE. So when you go back to the question, you say, what would you do here? I would argue that based off of the data, the rigorous data that we have, any of these are probably defendable and acceptable care for your critically ill patient within the first week. All right, so the last part of this is nuances about these recommendations. So we talked about these, only of the studies included in here only evaluate parenteral nutrition for a short duration, relatively few days to about a week. And it's for routine use in the ICU, not for a specific indication. So I'm not using it for sepsis, or I'm not using it for cholestasis. And as I talked about before, these were studies that initiated parenteral nutrition with fish oil containing intralipid emulsion. They did not change to it mid-course to try and offset a complication or a side effect or anything like that. So these data are not informative to answer the, should I change my fish oil, my intralipid emulsion composition to one of fish oils? None of the studies had the clinical outcome pertinent to the guidelines as the primary, and we definitely need more data here, and there will be more data in the near future coming out in this realm. You might say, well, I know of some meta-analyses that have different results. Why is that? And I'll show you some of those, and that's because they have different inclusion criteria for their studies. So here's the notes meta-analysis for two different analyses. One is omega-6 sparing effects. So this one is any mixed oil compared to purely soybean oil. Again, no difference. This is an overall mortality, no difference in overall mortality for this. Or if you look at the bottom is any fish oil containing parenteral nutrition versus non-fish oil containing parenteral nutrition. Again, not statistically significant, although it does favor kind of the fish oil as a point estimate here overall. But if you move on from mortality and you look at hospital length of stay, here, this one actually shows a significant reduction in hospital length of stay favoring omega-6 reducing, which is either not statistically significant for just comparing to pure soybean oil, but the mixed seemed to be slightly better, and the fish oil also seemed to be slightly better when comparing to either pure soy or a mix that doesn't contain fish oils. Infectious complications, no difference actually between them overall, but if you look at the group, which is fish oil versus non-fish oil, maybe a signal there that's statistically significant favoring fish oil. And here is overall and 28-day mortality. Overall is at the top, not statistically significant. 28-day mortality, which is before overall is longer than 28-day, may show a slight effect favoring fish oil. These are just fish oil compared to non-fish oil. Recommendation or intralipid emulsions. So why the difference? So here's a big reason for the difference. These are the trials that were included in the notes meta-analysis. And remember that I told you we had 4 and 6 randomized trials. They have more than the 10 overall that we have. These boxes, green, yellow, red, tell you the rigor of the trial from different potential biases. And you can see there's lots of red boxes here. These red boxes would be a trial that would not meet the rigor that we use to include them in our meta-analysis. And in fact, some of these are very small trials, not written in English, reported on a single page of a journal, and don't have all of the key clinical outcomes, which is why they're not necessarily included in our analysis, but maybe included in others like notes. It just increases the risk of bias in their study results when you include less rigorous studies that have a high risk of bias. All right, so here's the summary of recommendations for questions 4 and 5. Recommendation 4 says, based on findings of no clinically important benefit in providing supplemental PN, we suggest not initiating supplemental PN prior to day 7 of ICU admission. 5A says that we, based off of limited data, suggest either mixed oil ILE or 100% soybean oil ILE to provide to critically ill patients in that first week of ICU admission, with, we hope, more data to come to better inform that recommendation. And recommendation 5B is similar. We suggest either fish oil containing or non-fish oil containing ILE provided from the start to critically ill patients who are appropriate for starting PN within that first week of ICU admission. Again, with a relatively weak recommendation here because the data are just the robust data for supporting one way or the other on this are lacking and limit our ability to make a strong recommendation. Thank you for watching this presentation on an update on the 2021 ASPEN guidelines for the critically ill adult patient. I would encourage you to watch for upcoming Channel 1 videos on nutrition and learn more from my esteemed colleagues. Have a great day